network issues. Welcome to this month's public health corner. And I already have my guest with me. I will start by introducing my guest, and we don't intend wasting much time here. So my guest is Beta Okoma. I don't know if I mentioned the name properly. She's
Yeah, better outcome. Yeah.
all right. So she's a coordinator at Association of Reproductive and Family Health, and we'll be discussing um, bridging the gap, strengthening public-private partnership, and community-led interventions for better TB. TB, there is tuberculosis, and HIV care. Okay, so starting with the foundational understanding. Betha, please, I hope you can hear me. Betha, can you hear me, please?
Okay, I
Okay,
can hear you.
so starting with the foundational understanding, what is TB and HIV? And also, people may know this, but how are they connected? What is the nexus between TB and HIV?
Okay. So TB is a bacterial infection that is caused by Mycobacterium tuberculosis, and is an infection that affects the lungs.
Okay.
It also affects it also has the ability to affect the body as well. Like meanwhile, HIV we know is an immunodeficiency virus our immune system. Now, it makes the immune system unable to fight off diseases and infections. So that is HIV. The connection between HIV and TB is TB now as an airborne infection already exists. Anybody can have TB,
Okay.
but to develop active, can you hear me? Please confirm
Yeah, I
if you
can hear
can
you.
hear me.
I can hear you, please. Go ahead.
Okay, okay. So but those persons living with HIV, they are more risk of developing active TB because their immune systems are really low. Their immune systems can't fight off the they are more at risk of developing with HIV. So that is where you have the connection between TB and HIV.
All right. Thank you so much. Quickly, we'll go to our next question. Why do TB and HIV remain a major health concern, especially in indigent and um, undeserved communities?
Okay, so in underserved communities, there are socioeconomic factors that affect healthcare. Number one, they have poor access to healthcare infrastructure. There's overcrowding, there's poverty, and overcrowding really affects. For example, TB is an airborne disease.
Yeah.
So imagine someone with TB in an overcrowded environment, maybe in a room where there are so many persons, and TB is passed when a person who has the infection speaks, coughs, or releases any form of aerosols into the air. So, in overcrowded areas, they are more at risk of contacting the TB infection. There's poverty, and like I said before, poor access to health infrastructure. Then there's also stigma. So, all of these things affect and it's one of the barriers why undeserved communities are more at risk and the public health challenge to them.
All right. So I would I would digress a little from that same question, right? I hope you can hear me.
Yeah.
Okay. So most times when we talk about interventions like these, we oftentimes look at the affected community in this case. Now, have you ever been in a situation, or have you ever been part of a team that is working on maybe breaking a disease chain where you guys provide intervention for neighboring communities? Because when disease outbreak comes like this, most people tend to migrate to another community. So most times when they come with intervention, it is for the community affected. They don't talk about the other community that receives these people, because the truth is that when these people migrate from their community into another community, the population increases, and which is a risk factor for the disease there. So have you ever been in a situation where intervention is provided for both the affected community and the neighboring communities, please?
I'm going to say I didn't get your question. I think it's technical issues. The network is breaking a little bit. If you can recap, so I would get a full
Okay,
grasp
can
of
you
the
hear me
question
now?
you're
Can you hear
asking.
me now? All right.
Okay, it's
So
better.
I was saying that most times during interventions, right, it is only the affected communities that get interventions. However, during a disease outbreak, people tend to migrate from their community to the neighboring community. I hope you can hear me.
Yes, yes.
Okay. So, have you ever been part of a team where you provide intervention for both the affected community and the neighboring community? Because the truth is that when people migrate from the affected community to the neighboring community because of the whole infection, that is a risk factor. The population increases, competition increases. So we have little resource that should serve a lot of people migrating from the affected community to another community. So my question now is that, do they provide interventions for both the affected communities and the neighboring communities that had received these people?
Okay, so your question is how do we? I don't understand. How do we plan environments in communities, in neighboring communities, to ensure that during migration the other communities are not affected?
Yes, yes, something like that.
I kind of lost you a bit. I kind of lost you a bit at the towards the end. I don't know. The network is really crazy. I was following in the beginning. If you can just ask the question.
Okay. The question is, do they provide intervention for both the affected community and the neighboring community? Or have you worked with a team where intervention is provided for both the neighboring community and the affected community? Because most times it is only the affected community that we put into consideration. So did you get me?
Mm. Okay, if I'm going to answer that question, community interventions they are meant to be for all communities. Like we yes we have communities that are high burden to certain illnesses and infections. So usually when community
The network.
confirm if you can hear me.
Yeah, I can hear you now.
Okay, I think on and on. I don't know how much you heard. So what I was saying is that when community intervention is being mapped out to certain underserved communities that are high burden, because like I said, we have high burden LGAs. There are some LGAs that have you can see how do I put it now? The rate of the infection in those prevalence than other communities. So once implementation is once we are making implementation to go into said communities, the network by stakeholders, the community and while interventionist communities are also aware, and most times you find them coming into that other um, community with higher to also seek and access care.
All right. So the
I hope
network,
that
yeah,
answers the question.
yes, you did. The network is really bad, but we'll go to the next question. I hope you can hear me. I hope you can hear me. It's better. I hope you can hear me. Can you hear me, please? Can you hear me? Can you hear me, please? Please, if you can hear me, confirm you can hear me, please. Miss Beta, confirm you can hear me, please.
I can hear you.
Okay. Um. Okay. So let's move forward. I just hope you can hear me. So the next question is: what are the biggest misconceptions of tuberculosis and HIV? Okay. And
Yes, I can hear you now. I can hear you now. I can hear you
all
now.
right.
I can
So
hear you now.
the question is what are the biggest misconceptions about tuberculosis and HIV? Can you hear me? Can you hear me now? Please confirm if you can hear me. Please confirm if you can hear me. Please confirm if you can hear me. All right, while we wait for our guest, I would like to reiterate on what she has said so far. We talked about the nexus between tuberculosis and HIV. Now, it is very connected, yes, because I think having one predisposes you to having the other. Okay, so when we talk about tuberculosis, we can also talk about HIV. So I think my guest is back. Can you hear me, Miss Beta? Can you hear me now, Miss Beta? We are having serious challenge with our audio. Can you hear me now, Miss Beta? Can you hear me now?
Okay, I can hear you now.
All right. So the question I posed before was, what are the biggest misconceptions rather? What are the biggest misconceptions about tuberculosis and HIV, and how do they contribute to stigma and poor healthcare access?
Okay. One of the misconceptions about tuberculosis and HIV is that it is for a certain group of persons. TB is a poor man's disease, or HIV is a death sentence.
Okay.
So people don't understand that TB and HIV can affect virtually anybody.
Anybody. Yeah.
It can affect from the higher echelon down to the grassroots man. It's TB is airborne. So all you have to do is just be in the wrong place, probably someone who is infected with active TB, and that's all. HIV, we all know how HIV is spread. A lot of people, if they perceive HIV to be a disease that um, it comes as a result of promiscuity, which is not always the
Not true.
case,
Yeah,
as we
true.
know. Yes. So then in Nigeria and in Africa as a whole, there are lots of people who their uncles and their aunties in the village that's projecting diseases to them, which is not the case. So a lot of that affects people, and sometimes people don't want to seek care. They don't want to get tested. But I just want to let everyone know that TB is not from the village uncle. HIV is not from your villages, and it's not about God forbid. It's not my portion.
Yeah,
It's
true.
not a death sentence. TB is curable.
Yeah.
HIV is
It's
manageable
manageable.
with treatment.
Yeah.
Yes. So it's not a death sentence. If you're diagnosed with TB, please and please seek care for your sake and for the sake of those around you. It is curable.
Okay. Okay. So this will lead to my next question. Um, what are the main barrier preventing people? Because we've had a lot of people say, I am afraid. I am afraid of going to get tested. I'm afraid of. I don't know what the outcome will be. So, what are the main barriers preventing people from getting tested and treated with and treated if they have tuberculosis and HIV?
So the number one barrier is stigma and fear. Like you said, you're
Okay.
scared. People are scared of getting tested. In the first place, why would someone be afraid of getting tested? It's because of the stigma that's attached to
Attached to it,
these
yeah.
illnesses. If not, there's no, no one is scared of getting tested for malaria. You're not scared of going to run a malaria test. You're checking your full blood count or your sugar levels. Why are people scared of getting tested for TB and it's because of the stigma involved. Many people are afraid of what others would think if they get tested. Ah, you're testing for HIV, you're testing for TB. Ah, it means something funny must be going on, you know. So that's one stigma. Then we also
Okay.
have limited access in on underserved communities. Like I said before, treatment centers, testing centers sometimes are really far away and expensive. So limited access also affects is a barrier for getting tested and treated for HIV. Another thing is misinformation. Some people believe that TB can be cured with herbs. It can be cured with some mixtures. Just go to your babalawo and they'll sprinkle with some water and leaf around you, and
You don't even need to
you're
go to
you're done.
Babalawo. Those people that
So
shout
that's
on the at the bus stop. You don't need to go to Babalawo. Those people that will be shouting it at the bus
yeah.
stop. Mm. That one drug
I
can
don't want
cure
to
everything.
mention names. Some cleansers that will cleanse
Yeah.
you.
Yeah, that will cleanse you from everything you have, both HIV, both tuberculosis, both staphylococcus, everything. We know them.
Exactly. These are some of the issues. These are some of the barriers. So when people decide to go through that route, they are delaying proper treatment. And you know how we always say early diagnosis is always better. So
Yeah, true.
trying different things, you delay your proper treatment, and there's also financial barriers as well. Like I said, some of these treatments are really expensive, but before now, I would say I would say thank God for partners, NGOs that are sponsoring some of these treatments. There are so many partners and stakeholders, especially in our region, that has ensured that TB services are free. I'll take River State as a case study. TB services are free in River State all round. Walk into the nearest health center and you're good. So in terms of financial barriers, for now I can say that's covered, except maybe for transportation reasons, where healthcare services are far away from individuals. But yeah, those are some of the barriers that we face in TB and HIV services.
All right. Thank you. Thank you very much. So the next question, which comes to I think your field, since you're working in the private health institution. So what is the approach of private health institution um, as regards tuberculosis and HIV testing and treatment, and what are the gaps if there is any? Please, can you let us know? Did you hear my question, please?
Please come again.
Oh, you didn't hear me. Okay, so what is the approach of private health institutions, right, as regards tuberculosis and HIV testing? I think I've lost my guest. All right. So the next question was, what is the approach of the private health institution with regards tuberculosis testing or HIV testing? So we'll be having her very soon. I guess you did not get my question. Can you can you hear me? Okay, my question
I
was,
can hear
what
you.
is the approach of private health institution as regards tuberculosis testing and HIV testing?
Okay. So what their roles are?
Yes, yes, yes. No, not roles. The approach. What are the approaches of private health institution in tuberculosis testing, and are there gaps that we need to breach or we need to fill as regards um, tuberculosis testing?
Okay. Um I always say that private facilities are the backbone of TB and HIV treatment. In Nigeria, I like to use us as a case study because we're in Nigeria. Most persons, when they are ill, they go to private facilities. They go to their nearest PMV, patent medicine vendors, or the nearest pharmacy, or the nearest. A lot of us don't have confidence in the public
Public.
health facilities in our places. Most persons prefer private. So that's why I say the private health facilities are the backbone of TB and HIV treatment. But private facilities services are very expensive. We all know
Of
that.
course. Yeah.
And sometimes it's overwhelming for patients or persons who are trying to get tested. They are very that's really the biggest gap right now. So there needs to be a coordination between the public and the private. Should I say they need to find we need to like subsidize TB and HIV services in private facilities
Okay.
by the public. So who prefer to go to the private sector to get their health care would also have the subsidized rate. Well, it's already ongoing in most now. Facilities that the public is partnering with to provide subsidized care through the help of NGOs and other partners like WHO, USAID, they are supporting. Because I scratched that. Did I say you scratched
Yeah.
that?
Yes, yes. I
So yes,
wanted to.
I take that
Okay.
back. But yes,
Okay, okay, no problem.
that right now the gap is just finance, is funding, and I feel like what the government can do is to subsidize TB and HIV services in private facilities, because the partners who have been doing this, as we all know, they are pulling out. So yeah, that's one of the biggest gaps. So we just
All
need
right.
that coordination between the public and the private.
All right, thank you. And that's you already answered my next question, which was to give recommendations, which you have just done. So
Okay.
I would simply ask, can you share some examples of successful public-private partnership you have been part of? If you have been part of any, can you share some some of your experiences?
Okay, yes, I love success stories. So some of the public private partnerships that's ongoing right now that I have been part of is the PPM mix. It's a program or a project that's funded by Global Fund. We've had that in GC6 and we're doing GC7 now, where
Okay.
um, we have a great example is private pharmacists, patent medicine vendors are being trained to identify and refer TB cases.
Okay.
So
That's wonderful. Yeah.
what we basically sorry.
I said that's a good one. That's a good one.
Yes, yes. So what we do is we train all these local pharmacists. So whenever a patient comes or a client comes to the pharmacy and they complain of any of these symptoms, instead of just throwing some antibiotics at them
Dispensing
and
drugs
sending
to
them
them.
on their way home,
Yeah.
they will in turn ask them some questions and then test. They don't test, but we train them to be able to retrieve samples, and then there's a cascade that I can't go into right now, but they make
Okay.
sure they link this client to testing, and then if it's a case, they we enroll them on treatment. So yes, there's that going on right now in some states in Nigeria.
Okay. A lot of persons are not aware. So you're just saying it. For me, I'm just hearing it for the first time. I'm just hearing this for the first time, and that's a very good one. And that is one of the most important place where you can catch these people actually, because by the time they begin to complain of these
Yes,
symptoms, you already know what they're talking about. Okay, so
exactly.
quickly to the
So
next question.
mm,
Quickly to the next question. How can private health institution be incentivized to carry out more TB? I know what you just talked about. It's part of it. Okay, so can you give us more ways where by which private health institution can be incentivized to carry out more TB testing, more TB and
okay,
HIV
so
testing?
forgive me, I'm very passionate about TV. So many
I
times
know
when I'm
you
talking,
have always
I'm
you have been
leaning more
tilting
in the
towards that
TV
the part
direction.
of the
I'm
TB.
really passionate
Yes, yeah,
about TV. Yes.
yeah.
So um I think, like I said before, subsidizing treatments, also private facilities, private hospitals that are champions in TB and HIV services could have subsidized tax incentives, because these guys are actually doing the work. I know a lot of facilities they pay a lot of tax. If they can have a subsidized tax incentives, that would go a long way for them. Also, to provide free diagnostic tools and medications to private facilities, which
Who,
is already ongoing.
who is supposed to provide this?
This is
That's the
part of
government, right?
Right now, it's funded by partners, NGOs
Now,
and
what is
stuff.
the role of the government? This
NGOs.
our government. Eh?
Now that is the question we should be asking, because almost all the work in TB and HIV space is being championed by partners. Meanwhile, it's not meant to be so. The partners, the NGOs are leading, and the government is like following. It's supposed to be the other way around. The government is
Yeah,
supposed to be
true.
championing these activities and these reforms, while the partners would, support and go through. So partners are donating diagnostic tools to private facilities, especially those high burden private facilities right now. It has even been ongoing for several years, and free drugs and the like. So I don't know what we're going to do without the partners right now. Hopefully, going on with USAID, maybe our government would rise up to the occasion, rise up, who knows. We're looking forward to better days.
I really think, even though this live session is for the month of March, we should have a special segment for that US aid. There's a lot of things we have to discuss concerning that, but let's just leave that. So finally, to conclude, please just conclude by giving us recommendations on policies that should be implemented by the government to ensure better integration of public-private TBK. Because the truth is that if these two come together, both the public and the private, this thing will not be an issue. You get? So it's an issue because it is left for just one part, which is the private. Okay. So just give us few recommendations. You're concluding by giving us few recommendations on policies that can be implemented by the government.
Um, I don't know if you can hear me. So what I think
I can
is
hear you. I can hear you. I can hear you.
the government can improve, or should I say increase, funding for outreaches. They can do better. We can do better as a country. So we need to go into undeserved, underserved and remote areas, slums, IDPs, internally displaced, nomads, schools. They need to put in a lot of more funding into these areas, carry out outreach programs, and reach these guys. Then also, we need to expand access to TB HIV services in all the private clinics. Let me not say all, but in their pharmacies. But yes, we are doing a lot now, but we can do better. We can expand TB HIV services more. We can drive it more. So that's another thing. Then we also need to strengthen community engagement, support grassroots organizations, TB networks, HIV networks in rural areas as well. So that we can link people to care. Then educate people. People don't have a lot of health literacy in those areas. Like I said before, they believe in a whole lot of things. So health literacy, we can do that. That would also really help. So those are my recommendations.
All right. Thank you very much. So before you go, do you have an idea the location of IDP camp, any IDP camp in River State?
I don't. I do. I wouldn't
Do we
say.
have?
I don't think we have IDP camps in River State. Mostly in the northern and middle belt states. I can't say for sure. I don't have the facts to that.
All right. All right. No,
But
no
what we
problem.
have in River State, we have slums, and yeah, we have lots of slums in River State. So those are areas people can look into.
All right. No problem. Thank you very much for joining me in this live session. I appreciate, even though the network wants to tried, but we try to do what we're supposed to do. So thank you very much for honoring this invitation. I look forward to discussing more salient issues with you, like the ones I've mentioned. So I hope you will be able to avail yourself when that time comes. Please promise us now.
Thank you so much for having me. Like I said, I'm really passionate about TV and HIV, and I enjoy talking about these things. I could wake up from sleep and always talk about TV and HIV. So it is a privilege for me to have a platform like this, share my knowledge and my opinions on these things. So thank you too.
All right, all right. Thank you very much.
Sorry, one more thing
So, guys.
before we go and
Okay,
before I forget,
okay, okay, okay.
I would also want to all Women's Day, my people. Continue being strong
That's true. That's true.
and everything.
All right. Thank you. Thank you very much. Thank you very much.
Thank you.
Yeah. So, guys, see you guys in next month's live session. I promise you, we are going to be having another amazing guest. I know you enjoyed our guest today, so I know you're going to be. We are going to be having another amazing guest by next month, and we are already planning on bringing back our guest today very soon. She has a lot to offer us. So thank you very much for staying, and see you next month.
Bye, guys.